Again, thank you all so much for coming, and we've had amazing speakers, and we're excited about our next session here. This one is presented to us by Marsh McLennan, and the title is The State of the U.S. Health System and the Outlook for 2023. Does the future lie in healthcare disruptors or embracing belonging, or both? And our presenter today is Dr. Heidi Orsted.
Can you hear me back there, Pat?
Yeah.
Okay, great. Well, thanks for having me, everybody. I am pleased to be with you. I am a registered nurse, and I have my graduate studies really in population health and innovation. And so I'm pleased to be working with Marsh McLennan. And really, my work is in this kind of that bubble over there. So I work with my broker teams on behalf of employers. And what I do is I look very much at their data and how their data flows related to health, pharmacy, eligibility, disability, work comp, and figure out what's happening in the employer's health spend that can help the employer make decisions related to that very big check that the employers write every year. And so that's why I'm here, because I really have compassion for the employers and that great spend that they're seeing every year. So we're going to be talking about the U.S. healthcare system and the costs that you're seeing if you're an employer coming through your plan. We're going to look at the economic trends. We're going to look at that gene and cell therapy and their impact now and in the future. We're also going to be looking at the aging population and the impact that's going to have on our future, especially in the light of the fact that we have fewer clinicians projected in the future. We're going to look at the healthcare disruptors that have hit our system, you know, the good, the bad, and the ugly. And then we're going to talk a little bit of the science around relationships, belonging, mattering, and what that means. There's an 80-year-old study that has been going on since the 40s and 50s out of Harvard, and interesting science there. So, and the reason we have this picture here is we're going to be talking a little bit, that's my grandfather, and we're going to talk about what life was like for him becoming a doctor in the 1930s. Just think about that. So there's my grandfather. At the time he became a physician back in the 30s, he was a cowboy. Now, doctors, when they come out of med school, really they're pit crews. Very few doctors can really operate in the way a doctor could have back in the 1930s. And I'll tell you why. So my grandfather went to Creighton Medical School, like I said, in the 1930s. At the time, there were no antibiotics. There was no such thing as insurance. There wasn't an ambulance. His Oldsmobile was the ambulance. My grandfather didn't have any nursing homes. There was no such thing as a nursing home. There's no such thing as Medicare. People paid what they could. So it was a very different time, and that wasn't even 100 years ago. So his name was Doc. Everybody called him Doc. He practiced out of Omaha or Ottawa, Iowa. No such thing as insurance. Again, people paid what they could. Oftentimes it would be cucumbers, sometimes corn. He treated pets or livestock. So my dad told stories about coming down from the upstairs bedroom and seeing a dog splayed out on the kitchen table having surgery. Again, antibiotics didn't exist. When he graduated from medical school, he needed to know about 500 diseases, some medicine. Working in a small town, he delivered half of the babies. Dr. Walford delivered the other half of the babies. Most of them in the farm, if you think about it. Nobody came to the hospital. He was an orthopedist. He set all the bones. He's a primary physician. He was a surgeon. He practiced in infectious disease. He did his own labs. He would draw the blood, or he would look under the microscope and figure out if it's strep, whatever. You know, he was his own lab operator. He was his own pharmacist. He had all the pills that he could dispense right there in the clinic. And he was the ambulance to Sioux City, which was, and oftentimes my dad would be in the back seat because he liked to go to the farmhouses because he'd get a piece of pie. So, he was on call 24 hours a day. No such thing as malpractice insurance. Think about what that means in terms of our costs, right? And no such thing as medical bankruptcy. Imagine that. No such thing as a nursing home. Med school grads, so my oldest practices in family medicine now. She's a rural family medicine provider, not unlike his job. Insurance is complex now, and of course drives up the cost, doesn't it? It's unrealistic for anyone to pay out of pocket for medical care without the risk of bankruptcy. There are thousands of medications with as many side effects, many of which are cost prohibitive. There are over 6,000 known diseases. It's impossible for any one provider to know them all off the top of their head. We need PIT crews now. Providers must specialize, given the information they don't need to know, and patients are then passed from specialist to specialist to specialist. Again, malpractice insurance drives up the cost of care. Medical bills are the leading cause of bankruptcy now. And most elders live and die in nursing homes or senior facilities. Less than 100 years. So now we're going to look at healthcare costs, just to give you some perspective of how things have evolved, right? 60% of people reported experiencing healthcare cost increases outpacing inflation in the last 3 years. So think back what happened 3 years ago? Annual health spending in the U.S. increased 9.7% in 2020. Inpatient care costs have increased 37% across the board. And I'm the president of Minnesota's ANA board for American Nursing Association. I'm here to tell you part of that has to do with the shortage of nursing. All of a sudden you're paying travelers to come in and they cost about $100 an hour compared to your staff because your staff have burnt out and they've left. So there's a lot of confounding reasons as to why inpatient care has gone up, but that's one of them. 60% of people reported experiencing healthcare cost increases that outpaced inflation. We talked about that one. All of which leave companies in a difficult situation focusing on trying to keep costs in check. U.S. employers can expect health benefits to increase 7%, but through plan management, the shift can get to 5.6%. I work with brokers, and I've seen a lot of the ways we can kind of get around that. I'm part of those conversations. Today, the average cost for employers that pay for healthcare will increase 6.5 to 7%, and costing about $13,800 per employee. If they take Ozempic, you can double that. If you've heard of Ozempic in the news. The quarterly utilization for same-day services, you can kind of see many individuals chose to forego medical visits during the pandemic, the elective procedures, and even the preventative procedures. And so now what we're seeing is newly diagnosed patients and complication rates up this year. Employers are steering employees to high-value care. So what that means is you might have a relationship with a provider who gets incentivized for keeping care of maybe a list of patients, for lack of a better word. So what they're saying is if you have 20 diabetics or 200 diabetics, if your quality metrics meet a certain standard, you get incentivized to take care of that group of patients. So that's value-based care. And it has worked in the Medicare population, and so now they're moving that same philosophy over to the commercial population. And it works. I was at Health Partners in leadership when this all started way back in the 2010s, 2015s. So they're trying to incentivize the right type of care, so it's less fee-for-service. They're also including alternative networks and high-performance networks. So we're seeing some of our employer groups that are making reference-based prices. So they might say, we want to make if they're self-insured, we want to pay this person for our colonoscopies. We're going to pay this person a certain fee for our knees. We're going to pay this person a certain fee for our sleep apnea supplies. And we're going to go direct contract to these folks and get the insurance out of the middle. So they're being creative to try to mitigate the costs that are coming through. And the other thing we're seeing is people are recognizing the benefit of controlling chronic disease. Because if you're paying $13,000 on average for an employee, if you have somebody with diabetes who isn't managing that condition well and has a complication like a heart attack, you'll find that that cost of care went up to $35,000 because it wasn't managed well. So we're seeing employers invest in those chronic care solutions. And 34% of those employers are making those decisions. So now we need to talk about what's happening with our nation as the baby boomers are aging. So you can see here in 2035, we're going to have a flipped model here. So it's 2016, the blue, as you can see, were people that were the adults over 65, and the orange were the children. And come 2035, we're going to find that those two groups meet, and by 2060, the people over 65 will outnumber the children. So just think about that for a while. And who's going to care for this aging population? And who's going to pay for the Medicare costs of that aging population? There's a projected shortage of nurses, and there's a projected shortage of physicians. So now let's talk about our nation's youth. This is another statistic that is really troubling in the data diving that I do every week for my clients. 1 in 3 high school students reported persistent feelings of sadness or hopelessness in 2019. 1 in 3. And that has gotten even more. This is 2021. In the last 2 years, I continue to see these trends. Has anybody heard this in their, or seen this in their family or in their friends? Kind of this, yeah. I don't think social media has helped this trend. And you can see from these are years 2019, 2020, and 2021. Kind of those 3 diagnoses, what we're seeing in terms of the rates. The other thing we're seeing is the high cost of prescription drugs remains a source of frustration for employers, especially if you think about those cell and gene therapies that are coming through. So 50% of employers said that they were taking action to maintain specialty drug costs this year. What I'm generally seeing is kind of that medical costs go up anywhere from 5 to 7%, but the pharmacy costs are going up 15 to 20%. So cell therapy is when you transfer a live cell into the body. So either from your own body or from somebody else's body. And gene therapy is when you add a new gene or edit or remove an existing gene. And it's estimated that in 2023, cellular and gene therapies will total between 70 and 43, compared to just 7 per million members in 2020. So think about that. So 3 years ago, we had only 7 per million members, and in 2023, the rate has jumped that much. So 50 to 100 gene and cell therapies are anticipated to receive FDA approval by 2025, and 87% of employers are concerned about this $1 million treatment getting approval, and rightly so.
So it's what your point is, it's very expensive tech therapy.
Very expensive. I'll show you, as you can see here, I was at a client's meeting, it was Milwaukee yesterday, and I had done kind of a deep dive in their high-cost claimants because this is a new client to me. And so I was looking at their stop loss reports last year, and I scanned and I saw 2 very expensive medicines, one of which the person isn't on yet, but the member has hemophilia B. So he is definitely in line for the top medication, $3.5 million, which is a cure for hemophilia B. So over the course of his life, the cost of that care probably, this $3.5 million is cheaper. But if you think about turnover, will that member be with you for 50 years? Hard to say. But that's one example. So the top box of medications there, kind of went through them for you. are medications really to treat inherited disorders, right? So you can see a list of disorders there. They're all very long. I've probably but cared for patients with each and every one of those, but they're rare. And then the next half of the list is for cancers. And my youngest daughter just finished her PhD at Huntsman in Utah, and she studied cancer science, and she studied how to do this type of medication development. And so they're developing personalized medicines. So cancers that were incurable a year ago are now curable. So that's the good news in all of this, right? So it's ethically complex because you want to survive, you want your employees to survive, but it's not inexpensive. Even multiple myeloma was not a good diagnosis, but now there are treatments that didn't exist a year ago.
You know, the one thing to point out is when we talk about what's being discussed with pharmaceutical companies at the legislative level, it's this right here. Because the idea is if you have an employee in a given period, the outcome is phenomenal, the efficacy. And so who has to pay for it? You know,
Right.
if the employer, if they employ that individual or employ them as a dependent, or have them as a member, if they are dependent, you know, ultimately they have to cover the buck. And so how do we, you know, if you amortize on treatment that's less effective, then it makes more sense from a financial standpoint. But then you don't have the outcome that we want and we need. And so how do we get to that end game? I would say that this also, if you're familiar with stop loss,
Yes.
this is having a ripple effect on the stop loss market. So for those self-funded groups that are looking at this, it's a hardening stop loss market because they're concerned. Because this is what's going to puncture them. And if you have a specific level at 150,000, they're covering the balance up to 3.5 million. You can imagine if we start to see more frequency, Heidi, you may talk about this in terms of the drugs in progress to expand the list of applications. So this is going to become more prevalent versus less prevalent. And so how do you accommodate that from an employer standpoint? How do you consider that at stop loss levels? It's a really complex topic around these changes.
It is, yeah. Do you have the rest of the day?
So just look at that point, I assume everything that you see up here, you got to think of it in a 15 to 20 year term. Because you're looking at a patent, it's going to be in this environment for that 15 to 20 years, regardless of advancements in terms of.
Just like Humira, yep.
Yeah.
Mhm. You're exactly right. And I think, Pat, you hit on kind of a good topic. So as the possibility of these claims increase, you know, just thinking through how do the employers weigh their responsibility. We just kind of hit on that. And really what's come to mind for most of our employers is, do employers want the government to play a role in managing these high-cost drugs? 50% of large employers would welcome government intervention to managing these drugs, and 80% are concerned that current strategies to finance the therapies do little to address overall price. Because if you have hemophilia B or even hemophilia A, it's a genetic condition. So it could be that the mother carries the gene, she has 3 boys, and they could all 3 have this condition. So it's not just necessarily one family member, it could be a catastrophic cost to the plan. So now we're going to move on to kind of another conversation, and that is what's out there in terms of healthcare disruptors. Because you could just, I don't know if your inbox is like mine, but I probably get 8 emails a day about something new to the market. You know, this is going to be the next best thing to control costs for all of the employers in the world. And, you know, there are definitely some advances that I think are fabulous and will turn the needle for some costs. But then there are others that they try hard, but I'm kind of a skeptic. I will say I'm a little bit more like Doc Ockle in that regard. So I'll show you what I mean. This is definitely, I love this Apple Watch EKG or ECG. Does everybody familiar with that? Yeah. So got a call from my brother. It was December, and he said, I'm at Fairview Southdale. I said, what do you mean you're at Fairview Southdale? He said, yeah, well, my Apple Watch told me I probably had AFib. And I said, what? Sure enough, 3 weeks after COVID, got AFib. Went to his doctor, and he said, this has got to be wrong. No, doctor put the leads on. He was in AFib. Sure enough, yeah, saved his life. Single guy.
They made commercials about that.
And it's not. He slept with, fell asleep. We woke up in the morning. He had an alert.
Wow.
So, and you just look online. One person said the Apple Watch saved his life after my heart stopped 138 times. Yeah. Another thing they have is this fall detection feature. So this man fainted, hit his head, and whenever you have a hard fall and you don't respond, it calls EMS to your GPS location. So, I mean, things like this, fabulous. I was a geriatric consultant for years. I would have put one of these on all of my little old ladies if I'd known this existed.
Your life alert, but you
Yeah.
have to hit a button,
Yeah. Because if you're passed out cold, you can't hit your button.
right?
This medical home virtual hospital structure, are you guys familiar with this? Hospital at home? Yeah. So when I was a director of nursing at Methodist Hospital, and we tried this back in 2016. So what you do is you have a paramedic, and you have their capability to triage, provide EKGs, fluid, antibiotics, oxygen, IV fluids. They can run stat labs, stat imaging, and the patient's at home, watching Netflix, right? They can access antibiotics, they can deliver it to the home. You can have a skilled nurse come in, you can have rehab come in. All of that, right? Keeping the patient at home versus in the hospital bed contracting infections that they could avoid. It is a fantastic model. It is imperfect. What are the benefits? There are a lot of good benefits for the consumer. It's not inexpensive for the payer, except that it does avoid complications. It's a little clumsy to operationalize, and connecting the dots can be a little complicated too. So I think this model is sound. I think this is actually probably similar to what my grandfather did back in the day. They didn't have the hospitals in the way that they did in other, bigger communities. So I think that there is definitely promise in this as soon as it gets worked out. But watch this. I think this is going to go far. Especially, and what are the risks? We have to keep an eye on that. But in terms of the staffing in the hospital, it's hard to staff up. But for people who are not at risk, patients at risk of falling, can make good decision making, I think this is something we need to keep watching over. Another thing that I think has great promise is the capability to do virtual care, which obviously shot up during the pandemic, specifically for certain types of care. So Hinge Health is one example. It's a virtual physical therapy. I recommend it quite a bit to my employers as the only paid participant. It costs anywhere from $250 to $1,000 for the whole year. Unlimited physical therapy at the comfort of your home. No time away from work. Reduced pain, reduced likelihood of surgery, reduced depression, and people actually follow through on their physical therapy. And it's actually equivalent in cost to a usual physical therapy, but it lasts for a year.
Is it person to person, or is it just instructional video?
No, you talk to a doctor of physical therapy. So,
That's great.
yeah, it's a great product. I'm a skeptic, but this one's is sound. The other things that I think are great are, it's hard to get in to see dermatologists. I had a friend say the nearest she can get in is October. So you can get in with dermatologists virtually. That's a sound model, I think. Another thing that's a sound model is really this virtual reality. They're doing quite a bit of telehealth simulation. They're educating health students so that they're in the field learning how to do surgery, learning how to do different tasks that they ordinarily would get to do only on rare occasions, maybe in the ER, run a code, deliver a baby. All of those things they can see in a virtual reality field. Fabulous use of technology. And they're actually doing surgery from other locations. Think about that. It's like doing a video game. So the doctor could be in New York City and operating on somebody in New York State in a critical access hospital. Think about that. Far from MASH. Anybody know what MASH is? Anybody old enough to remember MASH? The other thing is Uberization of healthcare. I think this could work too for the right consumer, especially if they kind of think about Gen Z. The patient reaches out at their convenience and the healthcare professional responds using power of technology. I think it's not quite telehealth, but similar. It's for the people who will use DoorDash to get Starbucks. This could be something. for that crowd. Now this is where, the future, the capabilities we have now can cross an ethical they can spur an ethical conversation, I guess I should say. So it's possible, of course, this is what my daughter did day after day, to do DNA sequencing for any of us, right? You can do it, it's possible. So they've talked about the promise and perils of universal DNA sequencing for every baby at birth. So think about it. I mean, we do look for things like PKU, which is it's important that all babies be screened for that at birth. Because if we know it right away, we don't feed them the wrong foods, they won't have a developmental delay. So that gene, absolutely, we should do it. So, because we can, should we, right? There's ethics in that. So that's kind of an example. The other thing is, this is where it gets sticky. Mental health apps share your concerns with advertisers, and HIPAA can't stop it. Because HIPAA came around long before iPhone apps existed. They couldn't have predicted this mess. Work at health, privacy breach, class action investigation. You go on to work it, and then you say, I think I have a substance use disorder. That information goes to Facebook. All of a sudden you see ads for treatment centers. So now Facebook knows that you have this problem. BetterHelp class action lawsuit, same thing. Selling your information. Talkspace reveals client's email, violating client confidentiality. Cerebral receives widespread news attention after claims that the company was violating Controlled Substance Act by prescribing medication irresponsibly. One call and you get an Adderall prescription. Yeah. So, I think everybody came to market in 2020 and wanted to get the business, and it was sloppy. And the other piece is, many haven't done research. Again, I'm a skeptic. We have a vendor innovation council at MMA, and there's 30 of us sitting on it. So I've got my DNP, we've got our medical director, pharmacists, account teams, and we ask very hard questions. And we make sure that everybody's protected before we would recommend something. But if you're a consumer, you don't know this. So it's not uncommon for weight loss, exercise, meditation, mental health apps to lack any medical proof. Because the FDA has taken the position it doesn't need to assess the majority of healthcare apps. Imagine that. You presume that their marketing is true. Why wouldn't you? But be careful. And
It doesn't need to, or doesn't have the capacity to.
A little bit of both.
Every day there's got to be more
Hundreds.
introductions of new apps like that.
Hundreds of them. And if you think about the FDA's budget and their bandwidth, they're chasing down gene therapies, or should they chase down the Calm app?
Yeah.
And not all healthcare disruptors succeed. I'd say more don't succeed. So everybody remember Theranos? It's not that long ago. And Bright Health Group right here in Bloomington was the next best thing back in 2019. And now they went under, and 3 years later, 4 years later. And even Amazon, they've tried 3 times to go to market. And the problem is they're trying to have a telehealth model, and their services were not innovative enough. I've met with them. When they were trying to build it, we were meeting with them, and they just couldn't keep up. So we talked about 3 things so far. We've talked about what healthcare was like 90 years ago versus today. We've talked about kind of the evolution of costs of care and trends that are coming down the network in terms of inflation, medications, aging, young and old. We talk about disruptors. So now we're kind of coming full circle, kind of back to a Harvard study of adult development. So this is my grandpa. A few years, 1940s, he became a provider back for the World War II, people that came back to Kodiak, Alaska, after they had an injury. So by that point, he and my grandma had three little boys. So when he was serving in Kodiak, Alaska is when this study started. So I want you to kind of put that in perspective. So maybe there was Bactrim, one antibiotic at that time, right? And the soldiers were 18-year-old men. That's when this study started from Harvard, and it is still continuing. There's still some, obviously many of the men have died, but they studied these men every 2 years. 724 men, many of whom fought World War II. Longest studies of adult life ever done. And the men were varied in background, so many came from very poor families, some came from very rich families. Blue collar, one of them was a president. They surveyed these people every 2 years about their physical and mental health, professional lives, friendships, and marriages. And there's a great TED Talk on this. I encourage you to watch it. They had in-person interviews, medical exams, blood tests, brain scans. They even interviewed their wives finally, and the wife said, well, I'm glad you finally asked us, because they had been part of these their husbands' lives probably since the get-go. And with a front row seat on these men's lives, researchers have been able to track the circumstances and choices to see how they affect. What they were looking for, and they presumed, was, people that were richer financially had better health outcomes, or people that had maybe more privileged upbringings had better health outcomes. But the one thing that came through is none of that really was what mattered. Good genes are nice, but joy is better. So there's the person that ran the study, Robert Waldinger. Embracing community helps us live longer and be happier. It's amazing what he found. Good relationships are what keep us happier and healthier. Social connections are the one thing that was true across all of these men. A happy childhood has very, very long-lasting effects. But people with difficult childhoods can make up for them in midlife. And the way they do this, it turns out, isn't necessarily by getting out and having fun with your friends at the ski lodge or whatever. It's actually by passing something down to the next generation. So it doesn't mean you have to be a parent, but to do generative things. So maybe it's your niece, your nephew, maybe you're a coach, maybe you're a youth group leader. It's that act in and of itself that seems to be the thing that mitigates the risk you had as a child. So some trauma. Learning how to cope well with stress has a lifelong payoff. And that makes sense physiologically, too, if you think about it. And time with others protects us from the bruises of life's up and downs. And when I saw this, I was thinking about the youth mental health challenges that we have today, right? And I think, what is our cell phone use doing to our kids? Are they with other people? Do they learn how to cope well with stress? But that's for another day. They also found that loneliness kills, and it's as powerful as smoking or alcoholism. Now, being alone is different than being lonely. If you are alone and you're happy in being alone, that's different. But if you are longing to be with other people or you feel alone, that is a health risk. And when the study began, nobody cared about empathy or attachment. See, they didn't predict that was going to be the thing that was the differentiator. But the key to healthy aging really is relationships. And it isn't only the feeling of joy, it is the people lived longer. They had healthier bodies, healthier minds. And this is the one thing. It was the relationships they had. So that's what I have for you today. So lots to think about. I know it was kind of kittywampus, but I wanted to make sure you knew that it isn't just about Humira and it isn't just about gene therapy. It really is simple as having your relationships. And if you are somebody who's caring for young children, just think about the power of that, right? So, all right, questions, conversation. Yeah.
Just one back to the whole gene therapy and cost equation is that I assume those costs will kind of put it against the value that life in terms of what they could produce in the economy.
Yes.
The numbers kind of, there's a break even. Being very analytical, there's a cost benefit almost.
There is, absolutely, and I can tell you if I can, sorry for somebody.
And so my question is back to the, who's bearing that cost, right? If in the long run it's a combination of insurance and individuals, can insurances justify this? because they see the long-term benefit over a pool of people as opposed to taking
Case by
single
case.
individual situations?
Yeah.
How's this gonna play out?
I think that's a very good question, and I think, you know, when we started, you know, even when I started this job 5 years ago, we only had probably one. It was this spinal muscular atrophy. This was the first one, and I used to take care of a little girl who had this
Yeah.
disease, and she was not going to survive until her 10th birthday, but she was cognitively a brilliant little girl, beautiful little girl, and her family watched her die a little bit every day. And I was seeing her because she couldn't cough enough to prevent pneumonia from RSV, so I was giving her preventative medication. That's how weak she was. So, I mean, that's a life-saving drug. So in terms of the cost part of it, the problem is with self-insured employers, you know, of course, they write a check for all of their claims, except for what stop loss will cover. But what Pat said is stop loss is pretty smart. They'll start lasering these folks out. They'll say, we'll pay for everybody but the little girl with SMA. And then what do we do? And so we do have solutions out there. Some are out there. We've got captives. We've got, Pat could speak more articulately about what the insurance options are. But I think, in all honesty, I think with the growth of all of these solutions, I think the government's going to have to come in and figure out, okay, what are we going to do for this? Because the, you know, Orono School District can't pay for 5 times, you know, $2.3 million. That's their whole budget for the year. You know, you think about that.
Well, you know, there's one thing out there is the thing about stop loss is it's just a function of your broader healthcare plan. It typically represents about 20% of your it's the fixed cost component if you're self-insured. And because it accounts for 20% of the cost, what their intake of premium to balance the risk is always going to be upside down. And so if you had in the stop loss market, just like any other market, has multiple carriers, multiple insurance carriers, different types of appetite. And so the idea is, okay, if one insurer was taking that on and then that employee was employed somewhere else, now you have a different insurer. And so you can create maybe a subrogation mechanism where that new carrier takes that risk off, but they're not going to. They're going to height to the point where a laser is basically eliminating their access to stop loss to the employers all along for the entire balance, which is untenable.
I guess where I was going with it, someone's got to take a long view.
Yeah, that's
It's the only
true.
way. If you take
Yeah.
a view like that,
Yeah,
you're going to run out of headline.
you are going to.
Well, you need these. You have to have these because and we need to encourage more of them because the outcomes are significant, especially around the youth. And not to, but I mean, we all know that the empty and simply around what we can help children usurp in terms of their chronic conditions. It's just that's where it almost has to be legislative stuff because they don't create a high risk pool that these sit in and funded almost like anything else with taxpayer dollars. But you can't prevent this from happening because they have
The science is happening.
science is happening. This will become more prevalent. So.
Yeah, the
I think this
capabilities
happens.
are there. Once we can figure out how to map the DNA,
Right.
the cat's out of the bag.
Yeah.
Yep.
Is anybody around the world leading? Are we leading on
In the
this?
science on this?
Yep. Or is there a model, even in a smaller country, or a different medical system, or a different,
So like a
structure?
positive deviant out there?
That's
Are you
just-
asking about like how they're containing the cost or how they're doing the science?
more to that, more to
How
like
they're
a
leading?
model that seems sustainable and is actually setting us up for success in the future instead of continuing to be reactive.
Yeah, that's a really good question. The reason I asked one of my colleagues who works with Pat, because we sometimes look at Canada for that, in all honesty,
Okay.
to say, and sometimes we will actually work with them to get medications at a lower cost for our self-insured employers. And Strensiq is one of the medications that isn't on this list, but that is millions of dollars per year. And they had nothing to offer because they're hit with the same fees. So I think we're still looking to figure that out, but I am one who looks for those positive deviants as well. So somebody who figures it out first. Yeah, good question.
So, and these are U.S. drug costs, right?
Correct.
Yeah. So,
Yeah, fair.
so thinking about remote workers and virtual and things like that, you could have workers who end up working in other countries
Right.
as their home base and might be subject to alternative pricing that could be significantly lower potentially. All the
That's a good point.
conversation goes on about U.S. drug prices versus the rest of the world. And so part of me wonders whether long-term, if you're okay with a virtual workforce to begin with,
Right.
I mean, is there an incentive for the employer to identify, wait a second, the cost of this drug, if you're in the UK or if you're in Europe,
Yeah.
is half of that or something like that. We'll fund your trade.
That is not outside of
Global company.
That's not outside of what makes sense. I know I had one, I was working with Blue Cross of Kansas with a group, and they said they knew an employer that was sending people to Mexico for Humira because it was less expensive. They did the travel benefit. So it's examples like that. Self-insured employers are desperate to control for costs. So I hear what you're saying, yeah.
Maybe globally, think about global application. You have so many, countries that have statutory benefits.
Yeah.
In statutory benefits. So, good side, if they have coverage for this, great. But what I think will trickle out of this is, just like you see in certain countries where they say you're 55, you're not eligible for transplant because we need to give it to the young. And so I think you could see this evolve into creating caps saying, no, we're not going to pay for it. And so you just don't have access to it.
Yeah.
You have to go into being treated as a chronic condition, likely less improved outcomes. It's just, this is the quantity.
Yeah.
And it is a cultural.
All right. Any other questions? I think I've got myself.
Great session, lots of
Well, yeah. Again, if you have any questions, my email was on there. Bill knows how to get in touch with me. So.
And I think we'll have copies of all of these.
Yeah, can we send out a copy?
Of course, yeah.
So we'll get your latest copy.
Yes, of course. Nice to meet you all.
Thank you so much, Heidi. Well, round of applause for all of our speakers. They were fantastic.